Hello everyone, welcome to my YouTube channel. Our topic today is familial Mediterranean fever. Objectives of this presentation: history. Familial Mediterranean fever has been hypothesized to originate more than 3,000 years ago in the Mesopotamia. From there, the disease spread to Armenia, Turkey, and the ancient world. In the modern world, globalization has led further spread to countries far from the Mediterranean basin. Basically, an allergist, his name is Dr. Shepard Siegel. He's the first one described these attacks of peritonitis in 1945, and he called them benign paroxysmal peritonitis. Later on, Dr. Hubert Rainman from American University of Beirut described a more complete picture, which he termed periodic disease. In 52, two physicians, Henry Mamou and Roger Catan, described the complete disease with renal complications in 1952. As you see from this picture, the familial Mediterranean fever occurs mainly in the countries around the Mediterranean Sea, but later on it moved to other areas, as a part of the immigration that happened in the last century to Europe, United States, and so forth. Familial Mediterranean fever is a hereditary and autoinflammatory disorder caused by mutations in the Mediterranean fever MEFV. This is a name that you have to remember. Gene, which encodes a 781 amino acid protein called pyrene. While all ethnic groups are susceptible to FMF, it usually occurs in people with Mediterranean origin, as we mentioned, such as Arabs, Kurds, Greeks, Sephardic Jews, Assyrians, Armenians, Azerbaijanis, Druze, Turks, and Italians. Genetics. The MEFV gene is located in the short arm of chromosome number 16. Many different mutations of MEFV gene can cause the disorder. Having one mutation is unlikely to cause the condition. Having two mutations is the threshold for genetic diagnosis of FMF. However, most individuals who comply with the genetic diagnosis of FMF remain asymptomatic or undiagnosed. Whether this is due to a modifier gene or environmental factors remains to be established. Again, FMF is an autosomal recessive disease. It's a familial disease. That's why we call it familial Mediterranean fever. It's also an autoinflammatory disease. And basically, what autoinflammatory disease means, it's a disease of the innate immune system, okay, with no autoimmune abnormality. So it's not an autoimmune disease. It's an autoinflammatory disease. Autoinflammatory disorders are characterized by recurrent or chronic inflammation without signs of infection or autoimmunity. Dysregulation of interleukin-1 beta pathway is central to many autoinflammatory syndromes, especially the chylopyrene-associated periodic syndromes, deficiency of the interleukin-1 receptor antagonist, and familial Mediterranean fever. The need for definite diagnosis in the familial autoinflammatory syndromes has increased because of the advances in treatment options. A severe complication of these autoinflammatory diseases is type A amyloidosis, which often leads to renal failure. The risk of this complication is greatly reduced when the patients receive adequate treatment, in particularly colchicine in the case of FMF. In a substantial portion of patients presenting with clear autoinflammatory phenotype, the diagnosis can remain elusive, which indicates that other disorders remain to be discovered. Because of the central role of interleukin 1 beta in many autoinflammatory diseases, a trial of interleukin 1 beta inhibiting therapy can be warranted for diagnostic and therapeutic purposes. So this slide wraps the whole presentation, basically. Number one, this is a familial disorder. And number two, it's an autoinflammatory disease, probably related to dysregulation of interleukin 1 beta. And also, one of the major complications is amyloid A amyloidosis. These are the major autoinflammatory diseases. Top of the list, there is the Familial Mediterranean fever, or FMF. Then we have a mevalonate kinase deficiency, tumor necrosis, factor receptor associated periodic syndromes, otherwise we call it TRAPS, cryoglobulin associated periodic syndromes, or CAPS, deficiency of interleukin 1 receptor antagonist, or DARA. This is just a slide for all of these autoinflammatory diseases. Again, autoinflammatory diseases is a problem with the innate immune system. So what is innate immune system? This is the first responder in your body. Okay, the adaptive immunity is the second responder that involves B cells and T cells and so forth. So as you see from the picture, the innate immunity involves mast cells, neutrophils, natural killer cells, dendritic cells, basophils, eosinophils, and so forth. Innate versus adaptive. So the innate is the rapid response in hours. The adaptive is delayed response in days. Non-specific response to foreign molecules. Highly specific response to antigen. Response fixed in innate immune system. Response is adaptive. No immunological memory. With the adaptive, you have immunological memory. Pathophysiology of FMF. Virtually all cases are due to the mutation of the MEFV gene on the chromosome 16, which codes for a protein called pyrene. Various mutations of this gene lead to FMF, although some mutations cause a more severe picture than others. Mutations occur mainly in exons 2, 3, 5, and 10. The function of pyrene is not fully known, but it seems like it's involved in the generation of a multi-protein complexes called inflammasomes in response to certain infections. These pyrene-mediated inflammasomes, they induce the secretion of pro-inflammatory cytokines, such as interleukin 18 and interleukin 1 beta, in response to the enterotoxins from certain bacteria. The gain of the function mutations in MEFV gene cause pyrene more active in the body, which results in an increase in the inflammasome formation. So basically, to wrap this up, the mutation in chromosome 16 basically releases this protein pyrene, which gets involved in a complex, chemical reaction to form the inflammasomes. And the inflammasomes is the one that induces the secretion of the pro-inflammatory cytokines, such as interleukin 18 and interleukin 1 beta. In its basal state, pyrene is kept inactive by a chaperone protein linked to pyrene through a phosphorylated serine residues. The phosphorylation of pyrene is an essential prerequisite for the activation of the pyrene inflammasome. Okay, um, and probably this in FMF, the dephosphorylation of serines is sufficient to trigger the activation of the pyrene inflammasome. This diffusion mechanism is probably located at the level of B30.2 domain, exon 10, where most of the pathogenic mutations associated with FMF are located. It is probably an interaction with this domain with the cytoskeleton microtubules that's failing, as suggested by the efficacy of the colchicine. So this explains to us why colchicine, in fact, is a mainstay of therapy in FMF. Again, you can see here the pyrene. You see the MFV chromosome 16 and MFV gene, microtubular activation, and colchicine inhibiting this migration by affecting the microtubules. Clinical presentation. 90% of the patients have their first attack before they are 18 years old. All develop over 2 to 4 hours and last anywhere from 6 hours to 5 days. Most attacks include fever. That's why it's called familial Mediterranean fever. These attacks can show up into 6 different presentations, plus fever. Abdominal attacks featuring abdominal pain affecting the whole abdomen with all signs of peritonitis, inflammation of the abdominal lining. And in fact, it can look like appendicitis. And this happens in 95% of the patients. And unfortunately, this leads to unnecessary laparotomies. Joint attacks in 75% of the patients. Usually one joint is affected. Number 3, chest attacks, including pleuritis and pericarditis. Pleuritis occurs in 40% of patients and makes it difficult to breathe, to lie flat, but pericarditis is rare. Scrotal attacks due to inflammation of the tunica vaginalis are somewhat rare, but may be mistaken for testicular torsion. Myalgias. This is kind of rare in isolation. Erysipeloid rashes, a skin reaction on the legs that can mimic cellulitis, rare in isolation. This gives you kind of a picture of these rash. Look at the cellulitis-like picture. Of course, as you see, the joint also is affected here. Again, the cellulitis-like picture. So really, it's, familial Mediterranean fever can get mixed with so many diseases. I mean, unless you really have experience with FMF, you can easily miss it with something else. Acute attacks. The age of onset, again, febrile episodes may begin in infancy. 90% first attack by age of 20. But it can happen later, but it's rare. Duration, generally 1 to 4 days. Arthritic attacks tend to last longer. Frequency sometimes occur with great regularity, but more often the frequency varies over time, ranging from once every few days to several days. Exacerbating and relieving factors often unpredictable. Some patients relate them to physical exertion, emotional stress, or menses. Pregnancy may be associated with remission. Remember, stress is an important factor in inducing the attack. And this is something that you need to really discuss with your patients. Again, it affects joints, pleuritis, pericarditis, peritonitis. Peritonitis is the main stay picture. Fever and peritonitis. Okay? Next to this is the synovitis, all right, or affecting the large joints of the body. And the rash. And we said that this looks like cellulitis, gives you a cellulitis-like picture. The diagnosis is also completed with checking the acute phase response, such as C reactive protein, elevated white blood cells. Also, monitoring kidney functions is of paramount importance because of the amyloidosis. Okay. A genetic testing is available to detect the mutations in MEFV. Sequences of exons 2, 3, 5, and 10 of the gene defects detects an estimated 97% of all known mutations. And we're going to get into the diagnostic criteria. The diagnostic criteria of FMF doesn't include the genetic testing. But if you have an ambiguous case or a difficult case, it's better that you go ahead and get the genetic testing to confirm the diagnosis. Amyloidosis with kidney failure, AA amyloidosis with kidney failure may develop with overt crisis. AA amyloid protein is produced in very large quantities during attacks and the low rate between them, accumulating mainly in the kidney, heart, spleen, gastrointestinal tract, and thyroid. Of course, the most important one, as far as we're concerned, is the kidney, because it can lead to nephrotic syndrome and renal failure. I mean, also it can affect your GI and can cause malabsorption. It seems also patients with FMF have an increased risk of vasculitis. Complications. Again, we have to stress on this amyloid A, amyloidosis. This is the most severe complication of FMF. And it doesn't happen, although it can happen in other parts of the body, but this is the most important one. It doesn't happen in all mutations. Like, for example, M694V mutation is usually associated with amyloidosis, while the patients with mutation E148Q rarely have amyloidosis. So it's not universal, okay? Colchicine prevents the development of amyloidosis. So patients who have never been on colchicine or patients who present late in the disease process have a higher chance of developing amyloidosis. However, patients who have had persistent proteinuria, despite taking colchicine, should be evaluated for causes other than amyloidosis for the proteinuria. In other words, colchicine, guys, is the saving drug in patients with FMF. Without colchicine, there is a high chance you get amyloidosis, and thus you get renal failure, nephrotic syndrome, and renal failure. So if you're giving the patient colchicine, the patient is compliant with it, and patient started to develop proteinuria, you have to ask yourself, is this FMF or something else? Patients can present with asymptomatic proteinuria, while sometimes nephrotic syndrome or end-stage kidney disease can be the first manifestations of FMF. Male sex and Eastern Mediterranean origin are risk factors for developing amyloidosis. Other complications such as small bowel obstruction can happen from recurrent attacks of peritonitis that might lead to adhesions and bowel obstruction. I just had a case where the patient had interception from and adhesions from familial Mediterranean fever. Also, infertility, secondary to pelvic adhesions and ovulatory dysfunctions in female, while in males, fertility may be decreased due to azoospermia from testicular amyloidosis. Differential diagnosis, as I mentioned before, I mean, this can give you a picture of appendicitis, testicular torsion. It can be confused with other conditions such as acute rheumatic fever, different types of vasculitis, acute intermittent porphyria, and systemic lupus. The diagnostic criteria that most people use is called TEL-Hashimir clinical criteria. It has more than 95% and 97% sensitivity and specificity, respectively. TEL-Hashimir criteria. We have three major criteria. We have three minor criteria. The three major criteria are recurrent febrile episodes with serositis, which means, peritonitis, pleuritis, synovitis, whatever. Amyloidosis without predisposing factor, favorable response to colchicine treatment. Minor criteria are recurrent febrile episodes, erysipelas, like erythema, FMF in the first degree relative. So if you have two major or one major and two minor, you probably have FMF and you need therapy. How about if you have one major and one minor? This is probably a probable diagnosis, and probably you need further investigations. The most important of which is the genetic testing. Attacks are self-limiting, usually. Colchicine is a drug otherwise mainly used in gout, decreases the attack frequency in FM patients. The exact way in which colchicine suppresses attacks is unclear. While this agent is not without side effects such as diarrhea, abdominal pain, muscle pains, and hepatotoxicity, it may markedly improve quality of life in patients. The dosage is typically 1 to 2 milligrams per day. Development of amyloidosis is delayed with colchicine treatment. Colchicine should be continued during pregnancy. So I want to say, FMF is a chronic illness, guys. You can compare it to any chronic, illness. You have to, but you can control it. All right. We have drugs that control it, and this drug is basically colchicine. All right. Unfortunately, 5 to 10% of MF cases are resistant to colchicine therapy alone. In these patients, we add the interleukin-1 beta inhibitors, such as anakinra, and recently we have canakinumab. We're not sure whether these biologicals reduce the incidence of, or basically reduce the incidence of like amyloidosis or not. But we know for sure that it's controlling and preventing the flare-ups in patients with colchicine-resistant FMF. So basically, the algorithm, we start with simple analgesics. Step 2, we go to colchicine, and step 3, we go to the interleukin-1 inhibitors. Colchicine. Colchicine is a very old drug of vegetal origin. Its first use has been described for rheumatic complaints and mentioned in old Egyptian medical papyrus. However, this active compound, a tricyclic alkaloid, was first reported in 1955, and and its name was derived from Colchis, an ancient region close to the Black Sea, where plants of colchicum were widespread. In 2009, U.S. FDA approved the use of colchicine for FMF, the prevention and treatment of gouty attacks, acute pericarditis, and recently in the cardiovascular disease secondary prevention. Because it's an anti-inflammatory. It's a powerful anti-inflammatory, but not in every case, in certain situations. Mechanism of action of colchicine. Colchicine accumulates in white blood cells, cause them to decrease motility, mobilization, and adhesion. By acting on the microtubules of these cells, it inhibits the multiple pro-inflammatory mechanisms while enabling increased levels of anti-inflammatory mediators. It reduces the inflammation in joints, results from the precipitation of circulating uric acid. This is in case of gout, okay? Painkiller in gout. So again, the commonest two indications is gout, and next to, because gout is a common disease, next to this is FMF. And now also it's used in acute pericarditis, and it's used as a secondary prevention in cardiovascular disease. I want to mention something about colchicine, just so important interaction. Be careful with colchicine and statins, okay? So make sure that the patient is not on statins when he's taking colchicine, because it can cause, myopathy. Again, this is the colchicine. It concentrates preferentially in white blood cells. It inhibits the tubulin polymerization, and also it inhibits the NLRP3 inflammasome and caspase 1 activation and interleukin 1 beta release. Remember, we talked a lot about interleukin 1 beta. That's a main mediator in FMF. Inhibition of cell migration and adhesion, reduced release of pro-inflammatory cytokines. So basically, it's an alkaloid of a vegetal origin that has a very strong pro-inflammatory, very strong anti-inflammatory properties. Okay, so as we mentioned before, 5 to 10% of patients, they are actually resistant to colchicine. So then we have to use these interleukin 1 beta inhibitors, such as anakinra. Okay, and this anakinra is used on daily basis. Okay, it's given as an injection on daily basis, and this actually might interfere with compliance of some patients. Again, the anakinra competitively inhibit the local inflammatory effects of interleukin 1. Kenret, or the trade name of this drug, is generally safe and well tolerated, and the only major treatment-related side effects that appear are skin reactions at the injection site. Okay, the next generation is called canakinumab. It's a medication that reduces inflammation by binding again to the interleukin 1 beta and preventing its interaction with cell surface receptors. It's a class of medications called interleukin antagonists. Canakinumab targets interleukin 1 beta signaling, resulting in the suppression of inflammation in patients with autoimmune disorders. Bottom line, anakinra and canakinumab, they work on the interleukin 1 beta, but with different mechanisms. And this is a nice picture showing you these. So here the anakinra, okay, and this one here is the canakinumab. As you see, they work in a different places in the receptor area. the final the signal transduction basically is blocked. The final message here. Canakinumab or Ilaris. This one is given, subcutaneously, but it's done every 2 weeks, and that's the advantage of canakinumab over anakinra. Prognosis, okay? Outlook or prognosis. There is no known cure for FMF. Most people continue to have attacks, but the number and the severity of the attacks is different from person to person. Again, as I said, it's a chronic illness. It's like you're dealing with diabetes, hypertension, rheumatoid arthritis. Okay, you can control it, but you cannot cure it. Possible complications are basically amyloidosis that might lead to kidney damage and malabsorption from the deposition of amyloid in the GI tract. The prognosis of FMF depends on the frequency of the attacks and the development of complications. Generally, the attacks improve with the treatment and the decrease in frequency with age. Certain genotypes, such as 694V, are associated with a higher risk of complications such as renal amyloidosis and more frequent attacks. Hence, they are associated with adverse prognosis compared to other genotypes. I got most of the information from these articles in StatPro. Key learning points: FMF is a genetic autoinflammatory disease. It primarily affects populations originating in the Mediterranean region. If left untreated, amyloidosis commonly develops and may have a fatal outcome, chronic renal failure. The typical manifestations of the disease are recurrent attacks of severe abdominal pain and fever. Colchicine for life is the drug of choice in the treatment and reduction of frequency of complications. Thank you.